In this part, we're going to discuss mucus cells in odontogenic cyst. So the diagnostic dilemma here is that we can see mucus cells in many of our odontogenic cysts. So we already talked about the lateral periodontal cyst. And so it goes from a thin epithelial lining to these focal plaque-like thickening. We can see duct-like structures, but we can also have mucus cells. And again, this is most common in the mandibular canine premolar area, which is where we see about 70% of these. So using a mucicarmine here, though, we highlight our mucus cells within this particular cyst. Another cyst that we can see mucus cells in is our periapical cyst. So here's a patient who had root canal therapy. So this is a tooth that is dead. And this root canal therapy was done about 20 years ago. And the cyst is almost 2 centimeters in size. We see cholesterol clefts. We could see a giant cell reaction to this cholesterol, but we see a squamous line cyst here. And so particularly in our long-standing periapical or even dentigerous cysts, we can start to see mucus cells present as well. And so here again with the mucicarmine, that highlights our mucus cells. Dentigerous cysts also, you can see many mucus cells. Some have it more prominent than others. This is a pretty dramatic example. Here we also have inflammatory response as well. Here's another example of a dentigerous cyst with mucus cells, but here we also have cilia admixed. And so cilia is something that we'll see secondary with mucus cells. And so it's more common than you probably think. In one study that looked at serial sections, in our periapical cysts and also our dentigerous cysts, about 20% of them had mucus cells. And then when mucus cells were present, cilia was present as well in about 10% of the cases. So you don't usually see cilia in the absence of mucus cells, but you can see it as an additional feature. And this is more common in the maxilla than the mandible, and that's something that does indeed make sense. But something else is that these mucus cells can be kind of forming duct-like structures. And that's something that's going to come into play when we're talking about our glandular odontogenic cyst, because this is one of our diagnostic features that we're going to use to identify GOCs. So this speaks to why we need to be so stringent in identifying that particular cyst. So again, mucus cells and cilia are something that are more common than you might appreciate in our various odontogenic cysts. Now another type of cyst that we can see is our surgical ciliated cyst. And so here's a patient that has a history of actually maxillofacial trauma, and this is fairly remote, so this was years ago. You can see here a metal surgical tie. This is not as common nowadays. Now they usually use little titanium plates and screws, but we have a cyst here in the maxilla, and this cyst actually does not communicate directly with the sinus at this point in time. You can see that there is significant crown and bridge work. Other kind of histories that might point you to this is if there was a history of cleft palate surgery, a history of implant placement, history of extraction of teeth in the area, history of jaw surgery, which might be something like a Lefort 1 osteotomy where they move the jaws, and then also bilateral sagittal split osteotomy or chin surgery where they did like a mandibular chin advancement. And so with that, if they were to get a fragment of the sinus lining embedded in the bone, that's how you get a surgical ciliated cyst. And so what does it look like? Well, basically it looks like sinus lining. You see this eosinophilic kind of cuboidal epithelium, you can see mucus cells, and you can see cilia. So again, this kind of looks like sinus lining. We have an abundance of cilia present as well. And so that's our surgical ciliated cyst. Now, if you don't have a history of any previous surgeries in the area, you could ask, or you could sign it out descriptively and just point to that. Because obviously, if you just had this, mucus cells and cilia are something that you can see in other cysts in the gnathic region. So intraosseous salivary gland neoplasms are not terribly common, but if we were to see one, the most common one that we would have is a central mucoepidermoid carcinoma. So here's a patient that does have radiolucency in the posterior mandible. And what we see here is something that does look like a classic mucoepidermoid carcinoma: squamous epithelium, cystic areas, plenty of mucus cells. And another area, again, cystic areas, squamous epithelium, mucus cells, and so central mucoepidermoid carcinoma. And so if the question is, what's the relationship between our glandular odontogenic cyst and a central mucoepidermoid cyst? Do they both harbor mammal 2 rearrangements, and is GOC a precursor to central mucoepidermoid carcinoma? Or are there histologic features that overlap but no relationship? And the answer is indeed B. While there can be some overlapping histologic features, there is indeed no relationship. And so a study by Justin Bishop et al. Looked at 21 GOCs, or glandular odontogenic cysts, 5 central mucoepidermoid carcinomas, they're not terribly common, and using a dual colored break-apart FISH probe, you can see that we do indeed have positivity in our central mucoepidermoid carcinomas, but none of the GOCs were positive. So moving on to your case 6, this is a 68-year-old female who presents with a radiolucency in the right maxilla. And this is somewhat anterior in the bicuspid canine region. And so what we see here is that there are indeed multiple compartments to this lesion. We do see that there are focal thickenings. Even at low power, we can appreciate areas that are projecting into the lumen. You can even start to see these areas that we would refer to as whorls. You can see, again, whorls. You can see mucus cells. You can start to say that maybe these are papillary type projections. We can see clear cells that are more at the basilar type layer. You could see eosinophilic hobnailing, duct-like structures. And so you kind of start to work your way down a checklist. And you're looking for areas like cuboidal cells, microcyst, apocrine snouting, clear cells, variability in our thickness, which we certainly do have, mucus cells, whorls, multiple compartments, and cilia. And so this is actually a beautiful example, if you kind of scroll through your scan slide, of a glandular odontogenic cyst. And so radiographically, your glandular odontogenic cyst, you'd expect it to be multilocular. It's going to be more common in the anterior, more common in middle-aged females. One thing I don't believe we had on that slide was nice cilia. So that is indeed another feature we would expect. But if you have nice radiographic features like this, you certainly aren't expecting it to be something like a periapical cyst or a dentigerous cyst. So probably the best paper that's out there talking about the histologic features of glandular odontogenic cysts. And they analyzed the different features and analyzed their presence, and they basically came up with 7 or more features was highly predictive of a GOC. And so it becomes quite problematic when you just have a couple, particularly when you have 3 or 4, which is often what we're going to have in our long-standing dentigerous cysts that have mucus prosoplasia. And so we do need to be stringent and careful when we're diagnosing a glandular odontogenic cyst. And the question is, why is that? And it's because for our surgeons, these cysts can have a higher rate of recurrence, and they might even treat these with resection. And so we certainly don't want anyone resecting a dentigerous cyst or even a periapical cyst that just has mucus cells because it's been long-standing. So summary and take-homes. Mucus cells and cilia are common histologic features in our odontogenic cysts. We're going to see them more in our maxillary lesions. We need a high diagnostic threshold before we start calling things glandular odontogenic cysts. And mammal 2 can be of utility, particularly in our diagnosis of central mucoepidermoid carcinoma. Obviously, we want undecalcified material for that. And it's going to be important for distinguishing between central mucoepidermoid carcinoma and GOC.